Okay, so we're going to talk about the unstable pelvic injury. We don't care about the stable injury, okay? And in fact, if you start treating this one here, which is a neck of femur type fracture, as an unstable fracture in an elderly patient, you start putting pelvic binders on them and such, you actually do more harm than good. These are osteoporotic bones, and you're going to put about how many newtons worth of force of pressure by putting a binder on, you're going to make it worse. So unstable fractures are what we're talking about. These are the things to consider. What are the roles of the pelvic binder? What role does the fast ultrasound play? When do they go to the operating room? What's the role of external fixation? What role does packing play? Now, all the smart asses in the audience will turn around and go, unstable pelvic fractures. Fast positive theatre, fast negative angio. Really? Where's the evidence? You've got to know what the evidence is. So, just for you guys, I decided to go on a journey and look at all the evidence on this. And there was an Italian group that came together a little bit ago and in 2014 and did a consensus statement on this. So I said, I won't look at what the super specialists coming together did. I'll go through the literature and then I'll compare what I come up with what these guys said. I have a motto, trust no one, believe nothing. Okay, so when a resident presents a patient to me, I say, yes, thank you, let's go see the patient. Okay, because they've been fooled many times, I've been fooled many times. So I make sure that I see everything. So first, the anatomy, it's really important, and thank you to one of my registrars there who put me onto this app. It's fantastic. What was it? What's the app called? What is it? Anatomy Encyclopedia or something. I think I've got a reference to it somewhere. Fantastic three-dimensional stuff. So the ilium, the pubis, and the ischium. Now, they form this sort of triangular set of bones that form the cup for the joint. Okay, it's a ball and socket joint. It's a great little program. You put lymphatics in there, you put some muscles in there, you do all sorts of stuff to them. But it's important that we understand the anatomy, because understanding the anatomy and how the ring comes together in the pelvis is the key to understanding pelvic fractures and injuries. And so the sacrum is joined to the ilium by very, very strong ligaments, okay? And you get all sorts of issues with the ligaments, and that's where you can break and open the pelvis in that area. So this is the pelvic ring that everybody talks about and gets obsessed about. I love playing with this thing. And this is where you can actually cause the fractures, right? In the pubic area there and also in the sacroiliac joints. And that's where the pelvis can open. This innominate bone comes apart. A lot of vascular plexuses there. A lot of vessels. There's a huge amount of bleeding, and there's arterial. Sorry for the misspelling there, but there's an external iliac and an internal, and the internal iliac that sits across that sacral area and the sacroiliac joints is where we cause problems, and that's where you can get the bleeding that kills the patient. Okay, a lot of the venous stuff you can stop quite easily. The arterial stuff is what's difficult to stop. So there are some forces that cause issues. There's upward, downward forces that can occur. In traffic accidents, you've got the forward, the anterior, posterior forces. And these are the ones, the anterior, posterior, are the ones that usually cause the ring to open. And there are lateral forces. And the lateral forces cause a different type of injury to the other two. So if you think about the vascularity in this space and what you can actually damage, and we won't even put in the urogenital type stuff in there, there's a lot of damage we can cause. And so it's very important that we are mindful of what goes through that space. So the upward downward forces tend to cause this vertical displacement of the pelvis, and you can sometimes actually reduce that a little bit in the emergency department once you've got a pelvic binder on these guys, if you feel the two of them have moved apart. There's the anterior posterior. These are the ones that open the ring. Okay? These are the ones that give us the problem with the open ring. And so what happens if we open the ring? Big deal. All right? We just close it again, can't we? Well, the issue is that you've got a massive space in there that you can bleed into. Litres and litres of blood. In fact, you can almost bleed your full capacity into an open ring. How many litres can go into a femoral fracture? 2 to 3 litres. Right? You open your pelvis up, you lose your blood supply. So this sort of an injury, the unstable patient with vascular injury, has got a very, very high rate of mortality. The lateral forces are a different type of injury. They actually close the pelvis and cause tamponade. And if you put a pelvic binder on these guys, you can actually cause harm. Okay? You can actually distract the bones, break up the hematoma, the tamponade that they've caused, and make things worse. So it's important to understand the mechanism of the injury. Now, I know that when we get potential pelvic injuries, the ambulance tend to put the pelvic binder on them, and they should, because most of the injuries that we get will be anterior-posterior. But you do have to find out what the mechanism of the injury is, because these lateral injuries don't tend to cause the instability problems. Okay? It's the anterior-posterior that do. So what are the important facts? So this is some of the important stuff that comes out of the literature. Pelvic fractures are only a small percentage. You used to have about 10 years ago, mortality was quite high for these, 60%. We've got it down to about 20% now, okay, and even a little bit less than that. The pelvic ring bleeding is mostly by venous plexuses. It's when you get the arterial bleed that's going to cause you a problem. That's why we talk about angiography and those. And look at down the bottom. How do we screen for arterial bleeds? We either go CT if we don't have angio, but angio is the way to do it. And what's the evidence? Not much evidence at all. Okay, so we'll have a look. We'll have a look. So these are the Italian guys that got together. What was it called? The World Journal of Emergency Surgery. All these Italian guys, all the super ortho surgical trauma guys got together. 5 days of Chianti and antipasto and worked out what they were going to do with pelvic fractures. And they came up with, there are no randomised controlled trials, I'm sorry, right? And there are only case series. Well, I could have told you that, right? So let's have a look. What a case series? Level 4, level 5 evidence, okay? Randomised, double-blinded studies are what we're looking for. How many of them? Not very many of them at all. In fact, none, really. Okay, so what's the literature say? Gone through the literature. So it says pelvic binders are good. They reposition the fractures. They decrease the pelvic volume and they decrease blood loss. Not so much arterial, but mostly from the venous plexuses. And those things need to stay on until the pelvis is fixed or hemorrhage is controlled. Okay, so we had a patient come into Bundaberg recently that was in a motor vehicle accident, had an anterior-posterior injury and a penetrating abdo wound. Something from the car had gone into the belly. And the penetrating abdo wound was right in the superior border of where the pelvic binder was that the ambulance had put on. This guy had been somewhat hypotensive. He came in to the emergency department. So it's like the old thing of when you get the orthopaedic registrar who comes down and there's somebody who's broken both of their arms, okay? And they put them in a plaster and they say, go home, right? And you say, well, how are they going to wipe their own bottom? It's got nothing to do with me. I'm an orthopaedic registrar, I fix the bones, I'm moving on. Well, the surgical registrar says, penetrating abdo wound, I need to have a look. So he proceeds to take the binder off, right? And but I'm standing next to him. And so you stop him. Okay, you can't take the binder off, dude, but I need to look at the penetrating abdo wound. I know, but if there's a pelvic fracture in here that's significant, this guy will drop his blood pressure to his boots the second you do that, and then we're going to have to treat another type of patient. So what do? You take a quick pelvic x-ray first, make sure there's no fractures. If there's no fractures, you take the binder off, and he can willy-nilly stick his finger in it, do whatever the hell he wants to do, right? But the binder stays on until you are sure there's no significant fracture or until you get hemorrhage control. And hemorrhage control can mean that they need to go to theatre with the binder on, okay? Very important. So what do we know in the literature about pelvic binders? They give circumferential compression. They actually get a reduction that is very close to definitive stabilisation. They close the pubic symphysis. They're very good. Okay, it is the one thing that you can do very early on to save these patients. The important thing is to get it into the right place. So it's got to go over the greater trochanters and the pubic symphysis. And the way you've got to put 180 newtons force on there. 18 kilograms. Who goes to the gym here? Who goes to the gym? Somebody put your hand up. Please, somebody put your hand up. Oh, good. All right, well done. So you go to the gym. So you know what a 20 kilogram plate feels like, do you? You sure? All right, you don't look like you do, but all right, no, good, all right. No, sorry, having a go at you. So a 20 kilogram plate's pretty heavy. So you've got to put 18 kilos of force into this to close it up. Okay? That's a fair bit of force, yeah? So how much do you bench press? Don't boast, all right. That's all right, that's all right. How much do you bench press? How much? Okay, I've embarrassed him there. Okay, here we go. So here we can put, we don't have a formal one, we can actually put a sheet on. Tuck the sheet on, wrap it over. And you put some clamps on there to keep it in place. There's a great video of this New England Journal of Medicine site. Tighten it up. And you've got yourself a very good system. If you don't have clamps, just put a knot in it. Put a knot in it, pull them together, close the pelvis. See how that pelvis closes up? Very awkward moment there of holding the knot. And he closes that up. That's very simple, isn't it? You can do that. It took, what, 30 seconds. You have stabilised the pelvis as best you possibly can. The next stabilisation method is definitive treatment for this person. So, okay, the first thing in my flow diagram is going to be that I'm going to put a binder on. I'm going to put it in the right position. I'm going to put as much pressure as I can on to show that it closes the pelvis, and I'm going to leave it on there, and I will stop anybody from taking it off until I'm sure that there's no pelvic fracture, until the patient becomes a little more stable. Secondary to treatment, not just 5 litres of fluid. Okay, so treatment. What's the next thing I'm going to do? Fast ultrasound. So everybody talks about fast ultrasound. We want to be sure that the instability is not due to an abdominal bleed. So a pelvic fracture is going to cause a retroperitoneal bleed. We want to make sure that there's no intra-abdominal bleed. So that's a fairly classic positive fast where you get blood all around the liver there, kidney, liver, blood all around there, Morrison's pouch there. So you've got blood there, that fluid's blood. It could be ascites, but in a trauma patient it's blood. Okay, so you have something here that might be causing their hypotension. This patient needs to go and get a laparotomy. Okay, you can get blood, you can get a positive fast when you have a significant retroperitoneal bleed, or some of that blood might get through. Okay, so it can be positive, but it has to be a decision that you make with the surgeon as to what's really positive. So if you get a tiny little bit of something in the abdomen, the surgeon won't do anything. But those previous slides, these guys need to go to theatre and get their belly opened, okay, and find out where the bleed's coming from. And if there's a pelvic bleed as well, they'll pack them at the same time in theatre. So I'll send them to the operating theatre and I'll get pelvic stabilisation done. And most patients, 95% of patients are stabilised at this point. No issue at all, okay? So what's packing? You know, when they pack them and they try to cause tamponade. How good is packing? Well, pelvic packing on its own, we're not talking about angiography here, actually gives you very, very good results. So retroperitoneal packing has been shown to be good in kids as well, okay? And pelvic packing and a C-clamp, I'll show you what a C-clamp looks like in a second, is very effective at controlling hemorrhage. So that's a C-clamp. They draw a line between the anterior superior iliac spine and the posterior superior iliac spine, straight line across there, bang, this needle goes straight there. There's 2 big clamps, straight in, tighten it up, okay? That's the carpenters in the group tightening it up, so pelvic rumble, we're going to call that, all right? So C-clamp, very important. C-clamp and packing are pretty much almost as good as angio. And if you have angio that's delayed, all right, and you can't get into angio for 90 minutes, 120 minutes, packing and a C-clamp has shown to require less blood transfusion, less of anything. It actually works very, very well. Delay in angio is a problem. So the next thing I'm going to do is I'm going to say, look, can I get an angio in 30 minutes or 45 minutes? okay? And this is interventional angiography, where they have to embolise the arterial bleeding source. If I can't get that in that period of time, that patient needs to go to the operating theatre, because their outcome will be worse if they don't. And that's what we can find sort of in the literature as a trend. So if you can get it, they go to the cath lab there, and they get the angio done, they get embolisation to stop the arterial bleeding. And if they're stable, and you assume they are at that point, they'll go to ICU. And this is what it tends to look like. You get this your little blush there of arterial bleed, they get to work on them, and that's all embolised and done. And those arterial bleeds can cause death. So that's why we have to embolise those. The venous plexuses can be stopped through tamponade, but the arterial bleed is very difficult to stop. So if they go to theatre, if they've got a positive fast and they're stable afterwards, yeah, they can go to ICU or wherever. If they're not stable though, and that's 5 to 10%, what do we do with those guys? All right? We send them to angio after that, okay? If they're stable, they can go to ICU and they can get a CT. And a CT may show an arterial blush, very small one, and then we decide whether they go to angio or not. But if they're still unstable post-theatre, they need angio, okay? So they may need to be transferred from where you are if they're stable enough to be transferred. These are potentially unstable patients. The reason I put this talk up in this way is if you're working in a rural centre that doesn't have angio facilities like this, you're going to have to make a decision about transport at some point. And all you can do is get them in there, pack them, C-clamp them, and that should be good enough. Because the time to transport out is hours. You've got to act quickly, and then you might consider transport if there's nothing else that you can do. So angio, everybody throws angio around, they go straight to... If you're not working in a quaternary centre or, you know, a good tertiary centre, you're not going to have great, you know, angio facilities that will allow you to embolise. And they have to be activated in 30 to 45 minutes. The procedure itself takes 90 minutes or so, okay? So this is really, really important. So I came up with this as my flow diagram of looking at the literature, and then I went back to the Italians. And the Italians couldn't spell, but they've come up with the same sort of thing. So if you look at these guys, they've said, all right, what are we going to do? We're going to put a pelvic binder on and do a fast. If the fast is positive, they're going to go into the operating theatre and get peritoneal pelvic packing, and they're going to get any sort of external fixateurs like C-clamps. If they're unstable, they go to angio. If they're stable, they do a CT, look for a blush, an arterial blush, and they'll make a decision that way. If their fast is negative, they get external fixateurs and they get packed in theatre, okay? If they're still unstable, they've got to go to angio, okay? So we came up with exactly the same flow diagram based on the literature as these guys have done based on the literature and consensus. So these are the specialists. So not much in the literature to go on, but certainly enough for us to say. So this is what you need to know, though, in the acute setting. If they come in, if their fast is negative, truly negative, they don't need to go to theatre, okay? They should go to angio. If you don't have angio that you can activate within 45 minutes, and a lot of angios don't get activated for 120 minutes plus, procedure takes 90 minutes itself. If you don't, they need to go to theatre, they need to get packed, and they need to get clamped, and pretty much that's where your interaction will stop and mine will stop. Except if you're in a smaller centre where you might have to be involved in convincing people to take them to theatre when they're trying not to, or to take them to theatre when they want to CT them, because we don't take unstable patients to CT. Time is up. Well done. Okay. Any questions? You don't have to applaud to me. You don't have to applaud to me. What? Any questions? Anybody have a question? You can do this with all of your stuff. There's a... Oh, thank you. I've got a coffee. A question up the back there. Where are the mic runners? Do we have a mic runner? We have a medical student who's running with a mic. We have... What's the question?
Peter, if you're in a rural facility with no CT and your nearest CT is about an hour away,
Yep.
are you better just to bind them and basically bind and run?
You've got theatre though.
You've got theatre?
Patient's unstable.
Yes.
You're not going to send them an hour away anywhere.
Well, what?
Bind them straight to theatre,
no...
pack them. Surgeon's got to open them up and pack them. So if you've got an unstable patient and your whatever is an hour away...
Most of the time the theatre's...
What's that?
Most of the time we haven't got the right sort of stuff in theatre to do it.
Do you have a surgeon in operating theatre?
No.
No. Packing, pelvic binding is all you can do.
Yeah.
There's nothing else you can do. Resuscitate them, start blood products if you have to, right, and then get them to somewhere where they can put them into the operating theatre fairly quickly. There's no CT scanning, there's nothing for these guys. I mean, you're going to have to do your basic x-rays while they're there, your trauma series, so you get that done. But these guys, the most important thing is pelvic bind them, and there's nothing more you can do. Surgeon needs to get in there, open them up and retroperitoneal pack. Okay, we'll stop there because I think I've gone over time.